Hello, welcome to this presentation on general surgery short cases. This is meant to serve as a rapid-fire revision for the final year students taking the exams. Some of the material can also be used by those who are attempting postgraduate exams, such as the MRCS OSCEs. These are the contents that we'll be covering today. This assumes a basic knowledge about what the basic steps of examination are, and therefore we will not be covering everything. We will just be covering several key points. The format that we are usually most familiar with is the 10-minute station, and usually this is broken up into 4 to 5 minutes of physical examination with around another 4 to 5 minutes of questions and answers. In essence, there is no time, and therefore speed as well as familiarity with the physical examination is paramount. The focus of today's session would be on a physical examination set piece. A running commentary is strongly recommended for all surgical cases. The mental algorithm that you'll be thinking about may actually differ from the actual steps that you're doing. And it is important to remember that OSCE marking points are usually based on keywords, and therefore early mentioning of keywords and key physical signs on the running commentary will help you score marks. We will also go through some tips and tricks for specific scenarios, as well as some common pitfalls. So how do we package the findings? I find this particular format useful for me and also for many of my friends. We start with the diagnosis, and it is important to know the diagnostic criteria for you to be precise in your diagnosis. You also should mention that you want to rule out differential diagnoses, and they have to include the ones that are the most important ones, the most common ones, and also the most dangerous ones. If possible, some cases would allow you to elicit the etiology. Some cases would also have evidence of complications of disease or management, and also there will be some conditions which require an assessment of the severity, such as for malignancies. If you are able to reason a clinical stage, that would be beneficial. We've included here some of the statements that can help you in formulating your 20 to 30 second presentation at the end of the case. So chronic liver disease, hepatosplenomegaly, as well as different types of intra-abdominal masses are actually routinely taught in most medical schools, so we will not belabor the point here. There are some slight differences in terms of examining a patient with, let's say, a stoma, or a patient with an oncological condition, or end-stage renal failure. There are certain signs that may be less commonly well taught in school, or perhaps taught only indirectly. So just a word in general for the abdominal examination. Always pay attention to the stem. If the stem says to examine the abdomen, then you would start with the abdomen. And if it says to examine the abdominal system, then it is your choice to decide if you want to start with the abdomen or the peripheries. Understand that scars and stomas on the abdomen are your best friends in the surgery exam. With regards to the peripheries, try to group them into whether they are general or specific signs, as this would help you try to narrow the possible etiologies and related conditions to what you may be examining in the abdomen. So jaundice, pallor, and lymphadenopathy are must mentions, and specifically for the abdominal examination, you want to group signs, both peripheral as well as in the abdomen itself, into whether these are supportive of a chronic liver disease, these are supportive of an oncological condition, or these are supportive of renal failure or even end-stage renal failure. And always remember to examine the groin as well as to offer or even perform a digital rectal examination because there's always a reason in an abdominal exam to perform those. Again, going back to how we want to package our answer, always think about what is the underlying diagnosis, what is the cause for the diagnosis, and what are the complications that could have arisen from this. So this is not just for the short cases. These are things that you can apply at the end of a long case when you have to examine the patient as well. So these are some useful tips for stoma station. Number one is to know your definitions very well. Number two is always examine to look for the underlying or perhaps a unifying diagnosis, because a stoma never ever exists on its own just for its own sake. There's always a primary underlying condition, whether that is benign, such as in diverticulitis, or perhaps it is malignant, such as in colon or rectal cancer. Always listen to the examiner when they give you the stem, whether it's to examine the abdomen first, or whether it is to examine the abdominal system, in which you can decide for yourself whether you want to start with the peripheries or the abdomen. Some of the major pitfalls that a lot of students do is to actually fail to perform the digital rectal examination. It is very important to actually turn the patient and to actually inspect if there is even an anus, because that will give you a clue as to whether this is possibly an end stoma. The other big failure is to check for hernia, whether that is the patient's own native groin hernias, incisional hernias, or even a peristoma hernia. So this is a useful algorithm to help us decide during the physical examination whether this is not just a ileostomy and colostomy, but also what the underlying pathology could be. So for example, if I see a end colostomy in the left iliac fossa with a lower midline scar, and after that I turn the patient and there is no anus, in fact the anus is sewn shut, then this patient is likely to have undergone an abdominal perineal resection. And the most likely cause of that would then be anal rectal cancer. If let's say I think that anal rectal cancer is the most likely diagnosis in this patient, then I would then go on to examine around for evidence of metastases such as hepatomegaly, ascites that may suggest peritoneal disease, Virchow's node. I may even look for evidence of treatment such as Hickman line or Portercath. We'll cover a bit more in detail when we get to the oncology segment of this talk. And therefore it is important for you to not just examine the stoma itself, but also around the stoma, and also keep thinking about what is the underlying pathology in this station. So some of the common questions in the OSCEs would be mainly about definitions and indications for a stoma. So what is a stoma? Simply put, it is a surgical exteriorization of any hollow viscus. And it is key to understand that a stoma does not just refer to ileostomies and colostomies. This could involve any hollow organ. For example, a tracheostomy is the surgical exteriorization of the trachea, which is actually a hollow organ. Differentiating between an ileostomy and colostomy is pretty basic. We should have been covered in school. Indications for the stoma creation is also a common question. I'll leave it to you guys to read up on your own. But they are either for diversion, defunctioning, in the case where there's a distal obstruction or distal anastomosis that the surgeon wants to protect. And in cases where there's no distal bowel, right, then end stoma in itself is to allow for the passage of fecal material. What are the complications after stoma creation? These can be classified into general and specific. The anesthetic used for the procedure itself. For the specific complications, surgeons like to classify them into immediate, early, as well as late, post-operatively. These can be related to the primary surgery itself or related to stoma creation itself. And perhaps the specific ones that you ought to mention in exams would be peristomal hernia, stomal retraction, prolapse, necrosis, peristomal skin complications. And this brings us to the next point with regards to the principles of sighting of a stoma. Again, these can be found in most textbooks. But generally speaking, they should be within the rectus sheath at a location that is not affecting the patient's lifestyle with regards to the clothes that they may wear, as well as not underlying huge skin fold or pannus, because that would actually affect the ability to care for their own stoma, and has to be also well sighted away from any bony prominences. Therefore, that would allow for the proper application of the base plate of the stoma. The last thing is this discussion about the various underlying primary condition for which the stoma creation was performed. This could be classified broadly into benign malignant causes, of which diverticulitis, right, as well as colon or rectal cancer are the ones that every student should be able to discuss. Also remember to read up on the definitions of various types of colectomies. And lastly, if you get to this question about when you would reverse a stoma, you probably are doing quite well on the exam already. And the key thing to remember here is the primary pathology for which the stoma was created has to have resolved or has been dealt with. Number two, there has to be GI continuity. Right? So these are the two main principles. The other things will include patient factors, whether patient is fit for surgery, whether nutritionally the anastomosis would heal after you reverse the stoma. And in a consideration for, let's say, a reversal of a Hartmann's, you would consider how severe or dense the adhesions in the abdomen is. So now we move on to the oncology segment of the talk. These are some of the signs that would be good to elicit, not just for your short case, but also in an oncological patient that you clerk, even in a long case. It is a non-exhaustive list, and it's actually more important to try to integrate the signs into the case that you're clerking, rather than to try to elicit every single sign. Some of the pitfalls is the failure to be observant for these kind of signs. So here are some of the signs that a patient with cancer may have. It is important to remember that some of these signs could have more than one reason. For example, if the patient is jaundice, this could be due to a HCC with underlying cirrhosis, or it could also be liver failure from liver metastasis in the setting of, say, rectal cancer. It could also be due to chemotherapy-induced hepatotoxicity. So it's more important to be able to integrate all of these signs in the context of the case that you're clerking, rather than just memorizing them and then trying to look for all of them. Some of these are related to evidence of treatment, such as Portocath or Hickman lines. For example, if there's evidence of calf tenderness or edema in the legs, that would prompt us to then suspect, is this a complication of deep vein thrombosis, which cancer patients are more prone to. And therefore, it is quite important to be able to classify whether these signs point to an etiology, point to the cancer itself, the diagnosis, or possibly one of the complications of treatment or disease itself. In a similar vein, we can apply the same format and thought process to a patient with ESRF, looking out not just for evidence of ESRF itself, but also some of the etiologies and the complications and evidence of treatment that the patient may have had, whether this is dialysis, hemodialysis, peritoneal dialysis, previous kidney transplant, or other related procedures such as TPDI for tertiary hyperparathyroidism. These are not just useful in short cases, but also will help in the long cases, especially some of the vascular patients. Again, it is important that we don't focus on eliciting everything, but rather integrating some of these signs into which part of the case, whether it's the etiology, the diagnosis, or the complications of disease and management. So these are some of the signs that ESRF patient may have, and is classified by the regions in the body in which they can be elicited. However, it may be better to try to understand them and remember them in terms of whether these are evidence for etiology or things that point to the diagnosis of ESRF, or as evidence of renal replacement therapy or even kidney transplant. So with regards to etiology, some of the things that could be elicited include enlarged kidneys in the abdomen that may point to APKD, or evidence of insulin injection marks like lipodystrophy that could point to possibly diabetes as an etiology. It's also important to look for previous AVFs, AVGs in the arm, lines in the neck that may suggest that the patient is currently requiring hemodialysis. It's also important to look at the abdomen for not just a Tankoff catheter, but potentially previous paramedian scars that may suggest previous peritoneal dialysis. And with regards to transplant, one of the signs that can be elicited would be mass in the right iliac fossa underneath a Rutherford Morrison scar. I'll leave that to you guys to look it up online to see how it looks like. So now let's change track to hernia, which is probably the most common short case that students will get, and generally these tend to be what we call free marks, and it is important that you take this opportunity to score as well as you can for this station. Running commentary is highly recommended because if you're on the wrong track, examiners can attempt to guide you back to the correct track. It is important to use an algorithm to systematically narrow the differential diagnosis. And one tip is to always remember to start with the normal side so you don't forget to examine or end up missing a contralateral hernia other than the one that's most obvious. In patients who have pubic hair and who are not shaved, it's important to look very closely for any faint scars that may be hidden in the hair region. Another common pitfall is failing to define that this is a hernia or groin mass rather than a mass that's arising from the scrotum by telling the examiner that you cannot get above the mass. Some candidates may also forget to offer the lung abdominal exam as well as the DRE at the end, and some students may get trapped when they lack structure in answering some of the common questions relating to management. So this is an algorithm that can be used to help to narrow the differential diagnosis systematically. Do take note that this is not exactly the order in which the examination is performed. It is still inspection followed by palpation, then attempted reduction, and then demonstrating the protrusion or the lack thereof with occlusion of the deep ring. But let's say if you do get something like a scrotal mass in the exam, then you should go down a different pathway rather than down the hernia pathway. And these are some of the differentials of a scrotal mass. Just leave it for you to read it on your own. So how can you report your findings after examining the patient? It is important to quantify if it's a primary or recurrent by the evidence of scars or not, whether this is inguinal or femoral hernia. Very high chance that you're going to get only inguinal hernias in exams because femoral hernias tend to be operated on very quickly. Whether it is indirect or direct, just note that clinical examination is very poorly sensitive or specific to differentiate these two, and therefore just report what you see in the examination, or it could be both, what we call a pantaloon hernia. In the exam, there usually are no complications, but it's still important to make a show of having looked for them. This will include incarceration, evidence of obstruction, as evidenced by perhaps a distended abdomen, and strangulation. You will definitely not get these complications in the exam. And it's important to make a show of how you have elicited any risk factors. So here's a sample statement which you can use to describe your findings in the hernia exam. Common questions that you'll get in the hernia station would be surgical anatomy, such as the boundaries of the inguinal canal, contents of the spermatic cord, the location of the deep ring, the difference between the midpoint of the inguinal ligament as well as the mid-inguinal point. Differentials of a groin lump can also be asked, and it's wise to go through the different layers in the groin, from the skin all the way down to other structures such as arising from the blood vessels, lymphatics. Investigations wise, this may be a trick question, because for the diagnosis of a hernia, it is usually clinical. However, investigations can be done to help to plan for surgery, right? If patients need any risk stratification, or if you're worried about any complications such as obstruction, certain imaging may be performed. It's important to know with regards to management of this in the elective setting as well as the emergency setting. Indications for surgery would be that of a symptomatic hernia, or any hernia that is complicated, i.e. incarcerated, obstructed or strangulated. In the emergency setting, you may be asked, what is your initial management for a obstructed hernia, for example, and it's important to explain what you would do as the house officer on call. These would be simple things like inserting a nasogastric tube, taking bloods, ensuring good venous access, potentially counseling the patient for surgery. So these are common questions that it is a fair game to ask in preparation for turning houseman. Also important to know some of the common post-op complications. This is a good way to classify them: immediate, early and late, general versus specific, and specific to the hernia, specific to complications after hernia repair. I'll leave it up to you guys to read up on those things. Now we move on to the thyroid exam. Always listen to the stem and also look at the patient, because it usually tells you the diagnosis. The stem may start with please examine this patient's neck, and it could be fair game for it to be a thyroid station or a cervical spine examination station. And it's important to note any other clues in the stem, such as patient presents with weight loss, patient has been noted to be staring at her friends, patient has been noting anxiety, palpitations. These would point to doing a thyroid exam rather than a cervical spine exam. We'll go through an algorithm later to help to systematically narrow the differentials again. And for the neck exam in particular, it's very important to give the patient clear instructions to cooperate with regards to swallowing, tongue protrusion. Some of the pitfalls is forgetting proper exposure of the neck from the mandible all the way down to the clavicles. Usually in the exams, the patients have been prompted and primed to wear, for example, a tank top or a singlet, so that this is not a pitfall that you'll face. But it's important to be aware if the patient comes in wearing a necktie or wearing a polo t-shirt, it's best to get the patient to remove the top, unless the examiner says that you don't have to. Neck scars tend to heal well. Therefore, it's important to really look between the skin creases to look for these really faint transverse neck scars. It's important to examine for any complications, right? Such as any evidence of lymphadenopathy, local compression, and some of the mistakes that students make would be doing a merry-go-round around the patient, essentially looking from the front, the side, the back, and then realize they're missing something from the front, go to the front again. So in your practice, it's important to be able to try to finish all the steps that you need to do at each position, so you don't end up circling the patient 2 or 3 times. So this is an algorithm, and it's recommended that you do a running commentary so that the examiner can guide you back on track if you're going off. If it moves with swallowing, then it's either a goiter or a thyroglossal cyst. That means this probably is from the thyroid. And if it actually moves with tongue protrusion, then it's likely a thyroglossal cyst. And we examine the goiter, decide early whether this is diffuse goiter, like a diffuse enlargement of the entire thyroid gland, or is it just a thyroid nodule that is of concern. And the few C's that we are trying to answer in the clinical examination would also later on be our indications for intervention. So we look for evidence of compression of the various structures, the blood vessels, as well as the airway. We look for any evidence that may suggest a malignancy, right, such as lymphadenopathy, invasion. We also look for evidence of control of hyper or hypothyroidism, and evidence of Graves. So how can we make the exam smooth is to group the signs and then be purposeful when we move around the patient. So from the front, you should inspect and describe everything that you can see, right? And then from the back, feel everything, including the mass itself, whether it extends retrosternally, whether it's fixed, whether there are any cervical nodes. Also can feel the carotid pulse from the back as well. And then from the side, can perform percussion. And at this moment, you can already look at the eyes to see for any proptosis or exophthalmos. The rest of the peripheral exam, it's important to have a familiar routine. And then for the eye signs itself, know which ones are specific for Graves and which are due to just increased sympathetic activity. And if you are running out of time, you can just offer your leg examination, because it may be quite time consuming for the patient to stand up. So some of the common questions would be the surgical anatomy and important nerves, which is the recurrent laryngeal, as well as the external laryngeal nerve, as well as the vessels that is closely related to. The landmarks to intraoperatively to look for the nerve may be a bit out of the medical student syllabus, but that would be fair game for a postgraduate surgical exam. Apart from thyroid mass, there could be other differentials for neck lump, and it's important to know which they are, and one of the good ways is to classify them by the layers in which they arise from. For example, lipoma, sebaceous cyst from the skin, and subcutaneous tissue, carotid body tumor from the vessel, enlarged lymph nodes, which could be due to any reason such as infective, inflammatory, neoplastic reasons. The plastic can be primary or secondary. Investigations for thyroid case in particular, you will need your thyroid function tests as well as ultrasound of the thyroid. Be able to briefly explain the thyroid classification as well as the ultrasonographic features of suspicious thyroid nodule. It's even better if you can explain what is the Bethesda classification, which is the histopathological grading histopathological classification after fine needle aspiration cytology of thyroid mass. With regards to management, know the indications for surgery, the 4 C's, which is cancer, compression, control, which refers to whether it's uncontrolled hyper or hypothyroidism, refractory to conservative treatment. And the last C would be cosmesis. As a houseman on the ward, it's important to know your basic emergencies after a thyroidectomy, of which mainly there are 2. One is having a neck hematoma resulting in airway compromise. Understand that you have to emergently open the neck wound at the bedside to evacuate the hematoma. And the other emergency in inverted commas would be that of hypocalcemia. And this could be due to injury, devascularization, or accidental removal of the parathyroid glands as part of the surgery, and be able to explain what is a Chopstick sign as well as Trousseau sign, and outline the principles for replacement of calcium. With regards to the treatment of the goiter, you want to talk about what are the options for management of the goiter itself, as well as the underlying disease. And if you are, I would say, unlucky or lucky, you may get a discussion about Mann syndrome in a medullary thyroid cancer case, but usually that is not very common. Another mass in the neck would be the parotid. Again, listen to the stem and look at the patient. If the patient is a smoker, then likely this is a Walton's tumor, but a pleomorphic adenoma is still the most common histology for a parotid mass. Again, give the patient clear instructions, especially when you're examining the branches of the facial nerve. Some of the pitfalls are common for both parotid and thyroid glands. Improper or lack of adequate exposure, forgetting to examine the other side, forgetting the intraoral and the bimanual exam, forgetting to examine the cervical nodes because you assume that it is benign pathology, and you're almost certainly right, but you still have to make a demonstration that you are examining for evidence of malignancy. Again, a lot of students do a merry-go-round around the patient without being systematic in their examination, and sometimes you just forget to study the parotid because it's actually not very common in the wards, but it's actually very common in the clinics. So how can you make the examination smooth? Is to listen to the stem and inspect properly by describing how the mass leaves the earlobe and whether you observe any facial asymmetry from the front. Go to the back, feel everything, both the parotids as well as the nodes. And then from the front again, you would test the facial nerve and then perform your intraoral and bimanual exam. After you conclude that this is mass arising from the parotid, give a list of differentials because this is definitely going to be a question later on. Important things in the parotid Q&A would be the surgical anatomy, the surface marking of the parotid duct, which is a very popular question among examiners. The important nerves, the 5 different branches of the facial nerve, right, and the differentials of any salivary gland swelling. Know the classical 80% rule, right, which is that 80% of salivary gland neoplasms arise in the parotid, of which 80% are benign, of which 80% are pleomorphic adenomas, right. It is a bit more advanced to have a discussion about the different imaging modalities, and these will include ultrasound and possibly cross-section imaging, whether that's a CT or MRI, if there is suspicion that this is more than just a benign pathology. Then there may be questions a bit about facial nerve injury after surgery, the function impact, especially if the branch to the orbicularis oculi is injured. This will result in exposure keratitis, right? And some of the management strategies would be that of eye drops as well as potentially a tarsography. So this is important for your medical neurology exam as well. We go on to, I think this is the last segment on legs. We just talk about the vascular exam, as is probably more common than the venous exam. Again, listen to the stem and look at the patient. Examine the lower limbs could be the initiating stem for not just a vascular exam, but also a knee exam, a hip exam, potentially even a lower lumbar spine exam. So listen to the stem very carefully. Commonly, there will be a stem about claudication or potentially about tissue loss, right? Sometimes they may tell you the patient is a smoker in the stem itself. Give the patient very clear instructions, right, with regards to walking, elevation of the leg for your Burgess test, right? Be very clear about your definitions of what is acute limb ischemia, what is chronic limb-threatening ischemia, or some older examiners may say critical limb ischemia, right? One of the tips is to use a running commentary when you're feeling the pulses, especially the surface markings of where you're looking for the pulses, because this may help you to answer some of the questions that they have already planned for later on. Pitfalls would be forgetting proper exposure again. You should expose from belly button downwards. Patient can keep the underwear on. Right, looking for evidence of walking aids, looking at the footwear itself, especially when the stem is to examine the lower limb. Right. Some students may miss out on wounds or calluses between the toes and also under the heel if they do not look closely enough. And if there's a dressing, right, you should always open it up to have a look at the underlying ulcer or wound, unless the examiner says that you don't need to do it. Some of the common questions in the vascular station would be asking you questions about surface anatomy. So how you can make it smooth is by actually incorporating these surface markings into your routine already. What you can do is say I'm currently feeling for the dorsalis pedis, that is just lateral to the extensor hallucis longus, right? Or I'm feeling for the popliteal pulse, which is between the two heads of the gastrocnemius, right? Some of the definitions of acute limb ischemia, as well as chronic limb-threatening ischemia, and also how to differentiate them. One being more likely to be due to an embolic phenomenon, and the other one more likely due to thrombosis. Okay, and what are the clinical signs and symptoms, right? So the definition of a CLTI, right, is that you have either rest pain or tissue loss, right, associated with objective evidence of vascular compromise, whether this is due to a decreased ABPI or reduction in absolute toe pressures. Okay. As a house officer, you are expected to know the management of risk factors for vascular patients, including optimization of blood pressure, dyslipidemia, diabetes, smoking cessation. Right. It's also important to know the conservative management for claudication, which would include starting of aspirin as well as statins. This is mainly for prevention of cardiovascular mortality and morbidity. If you get to the question about surgical options for an acute limb ischemia or CLTI, it means that you're probably doing quite well. This would be whether they are open or endovascular procedures. I'll leave it up to you guys to read more to figure out how you can better answer this question. But that is a good way to help you classify your answer. And one of the common questions that examiners like to ask, and it's actually very important for your day-to-day work, is how you would manage foot sepsis. It's important in this case to know what's the definition of sepsis based on the sepsis 3 guidelines. Right? This would be a dysregulated host response to an infection. And what are the components of the 1 hour bundle, right? Things such as taking blood cultures, checking the lactate, giving broad spectrum antibiotics, fluid resuscitation at 30 ml per kilogram, and also potentially starting vasopressors, right, if the MAP target of 65 cannot be achieved. Right? So these are in fact the questions that would sort of determine whether you pass or fail, right? Because these are things that are expected of a house officer. So here are some rubrics for self-practice